I'm going to touch briefly on scaphoid fractures and when you should fix them, and a little bit on how you should fix them. All right, so I think about the scaphoid as an awkward but important bone. I think of it as a link between the proximal and distal carpal row, so it acts like a tie rod. So I'll use the analogy of a car where a tie rod is linking your steering box to your wheels. It's actually what ties your wheels. In the case of your wrist, the scaphoid is what links the proximal and distal rows together and moves them around. And then I like to think about it as awkward but important. Why is it important? It's the most commonly fractured carpal bone. The incidence is 1.47 fractures per 100,000 person years in the general population of the United States. It's a 2-to-1 male to female ratio, and it's 11% of all fractures in the hand. And the mechanism is usually the fall onto an extended wrist. Okay, this is the Herbert classification of scaphoid fractures that I like to use because it breaks things into stable versus unstable. The stable fractures that you see, the A1 and A2, the scaphoid tubercle and the incomplete scaphoid waist fracture, we typically treat with cast immobilization, whereas the unstable fractures, the oblique scaphoid waist fracture or the complete scaphoid waist fracture or the proximal pole fracture or the transcaphoid perilunate fracture that Dr. Santiesteban is going to talk about next, we typically treat with surgery. I will say that the B2 fractures that are complete waist fractures that are minimally displaced, it is debatable whether they should be fixed or not. And we'll talk a little bit more about that. So why are they awkward? So if you don't treat scaphoid fractures, they're not going to heal. And if they don't heal, this leads to degenerative changes in the wrist. So as my old mentor at USC, Dr. Zvanovich would say, this is a big problem, okay? So you can see here, this is an example that I just recently saw in clinic. This is a 32-year-old gentleman that hurt his wrist 3 years ago, never sought treatment, and then showed up into my clinic with this proximal pole non-union. You can see that he has arthritic changes in the scaphoid, in the radial styloid, and he has a DC deformity on the lateral view. All right, so the most important thing about making sure that these don't go on to non-unions is treating these in a timely fashion. Retrospective studies of scaphoid non-unions from many countries show that about 30 to 50% of patients had a delay in treatment before they showed up at least 4 weeks. Even more powerfully, in Denmark, they showed that if you delayed treatment by 4 weeks, you had a 45% chance of having a non-union. And if you could learn anything from this talk, this is the one paper that I want you to take home. This is the SWIFT trial. This was done in the UK. It's a multi-center, open-label, randomized superiority trial that was published in Lancet in 2020. And basically, they took all of their scaphoid waist fractures that were complete and minimally displaced, and they allocated them in 2 groups, either immediate fixation or aggressive casting. And the purpose of the trial was to see whether or not you could treat these with casting versus fixation. But the real take-home is that because they treated these immediately, there were only 5 non-unions in their entire group that they followed through for a year. So they had a 1.1% non-union rate in all of their patients that they treated. So this shows that if you treat them immediately, your non-union rate is going to be much lower. Okay? So because diagnosing these fractures is so important because of the timing, what is the best way to make this diagnosis? We know that x-rays can be negative up to 25% of the time in acute scaphoid fractures. And I'll show you a very nice example of this at the end of my talk. So when somebody comes into the ER and they have, they've fallen onto the wrist and they have pain in their wrist and they continue to have pain, you're probably gonna wanna order advanced imaging. We know that MRIs of the wrist have a near 100% sensitivity and specificity for scaphoid fractures. So if you're looking for an occult scaphoid fracture, my imaging of choice would be to get an MRI. If I want to find out whether or not a scaphoid fracture is displaced or not, I would like to order a CT scan because they're not quite as sensitive as MRIs, but it gives you a better idea about where the bone is and if it's displaced. So now that we made the diagnosis of a scaphoid fracture and it's displaced and we want to fix it, or if it's a proximal pull, how do we fix it? The mainstay of scaphoid fixation are headless compression screws. These can be inserted dorsally or volarly. They can be done percutaneously. They can be done open. I prefer conical screws like the AccuTrax because they provide more compression as compared to the traditional shank design of the Herbert screw. All right. The other important point about fixation of scaphoids is that centrally placed screws have greater stiffness and load to failure, and that longer screws have less fracture fragment motion. So the longer the screw that you can put into your scaphoid and the more central the screw you can put in the scaphoid, the better. As far as technique, it's been shown that in vivo it's easier to place the screw in the central axis percutaneously from a dorsal approach as compared to a volar approach, but there's no difference in union rates in that series. In a cadaveric series done by one of my co-residents, they show that percutaneous volar insertion requires a trans-trapezial approach about 20% of the time. So if you want to put that screw into the center of the scaphoid from that volar approach, you have to go through the trapezium about 1 out of 5 times. Okay? So now, personally I prefer to do a dorsal percutaneous approach for minimally displaced scaphoid fractures. And this is just a diagram of how I like to do this. This is something that was first published by Joe Slade. And so what you do is that when you're imaging the scaphoid, you want to pronate the wrist until the scaphoid looks like a cylinder, as you can see in that first picture. And then you want to flex the wrist down until you see the ring sign on the right, and that's the central axis of the scaphoid. I have it marked with a red dot. Then after you insert your guide wire, you check the AP and the lateral with the wrist inflection to make sure you're on the right course. All right, so these are a couple of cases that show kind of the 2 tenets that I want you to take home. The first case is a 29-year-old male who was playing soccer, fell onto his wrist, and has this kind of oblique scaphoid waist fracture that you can see on the right. He was taken to the operating room, underwent a dorsal mini open approach, and had this screw placed down the central axis of his scaphoid. It was done within a week, and you can see that at the 3-month follow-up, the fracture is healed, he had no pain, and he was released to full activity. Okay? Now this is a different case. This is a 55-year-old gentleman who is a plant manager at a biotech company. He was in a motor vehicle accident of November of 2022. He presented to the ER with pain in his wrist. He had x-rays that were read as negative, and then he was sent to his primary care doctor. His primary care doctor told him that he had a wrist sprain. He was sent to physical therapy for multiple rounds, and then he was sent to my office 15 months later. So this patient has a scaphoid waist non-union after not being treated for 15 months. So he's on the schedule for tomorrow. So with that, yeah, thank you.